Thanks, and good afternoon. I think I'm here because of the use of the global burden of disease as background input to this important commission report. And I was asked to comment a little bit about the history of mental health assessments in the GBD and how our perspective of how they've been used and where they might be going. Is that is that the instructions? So the global burden of disease that does get used rather extensively in the mental health community and represented in this commission report started 27 years ago in 1991 as an initiative of the World Bank. And it was an interesting issue because the World Bank in 1991 had decided that their annual policy report, the World Development Report, would be on health. And they asked the team leading the WDR in 1993, and they start a couple of years in advance, asked a really basic question, which is, what are the world's most important health problems? And it turned out, remarkably, in 1991, there was nowhere to go and get that answer. And thus was born the idea of trying to quantify in some standardized way health outcomes. And through happenstance or random chance, Alan Lopez at the World Health Organization and myself were asked to try to quantify the health problems around the world. And we started down that road. It was two of us and a team of student research assistants. And as we started to sort of pull the data together, there was lots of steps in that process. One is you needed to have a metric that would allow you to say what's a big health problem versus not. And metrics like deaths seemed obviously wrong because deaths at age 90 aren't really the same thing as a death at age 2. But nor is simply counting years of life lost. And we rather quickly moved and captured the notion from the literature in the 1960s around measuring loss of functional health. And that's important because it was that decision that the right metric for thinking about health problems, how big are health problems, was essentially a year of healthy life lost. And we ended up calling that metric in the GBD, and that name is stuck, a DALY, a disability adjusted life year, with two components, years of life lost due to premature mortality and years lived with disability, and combined give you that sort of more holistic view. And unknowingly, we had wandered into the world of parity, namely parity between mental and physical health, although we had no intent of doing that, right? This was a purely measurement task, and it seemed like the obvious logical thing, which is that we wanted to capture both fatal and non-fatal outcomes. So fast forward a couple years forward, and we have the first preliminary results from that overly ambitious, nearly absurd exercise to have a group of 10 people try to pull these numbers together. Nevertheless, we came up with numbers, and to the surprise of Alan and I, one of the largest causes of burden was the category that we lumped together at the time of neuropsychiatric conditions, which was both mental health, substance abuse, and a series of neurological conditions. And one of the most important causes of lost healthy life in the world was depression. And when we first had the preliminary results of that, we said, oh, this must be wrong. This can't be true. And although we kept trying to make these results go away, they didn't. And in fact, it turned out that they stuck. And so when we came up with the final numbers for 1996 and published them in 97 in the Lancet and a series of books, there we had a very prominent role for mental health. And it stayed there in all the subsequent efforts around the GBD. So just to reassure you that initial pretty limited evidence-based finding has turned out to be sustained, and if anything, as we've added more conditions, general anxiety disorder, conduct disorder, a number of other conditions to mental health, more depth on substance abuse, the quantified burden has actually just grown, so that now in the results from the global burden of disease that will be published in November, the GBD 2017, we have this prominent role for all the years of healthy life lost in the world. About 6.75% are from mental health and substance abuse. And that fraction, because of demographic change, not because the rates so much are going up, but because of demographic change, is increasing. Now, when we first published the GBD results in the scientific literature in 97 and some other papers in 96, the same skepticism that Alan and I greeted these findings with prevailed in many of the discussions that we participated in, because it was contrary to most people in cardiology or oncology or other fields to their expectation. And I think some of those debates, despite a lot of quantification since, continue. Now, the interesting thing was, after the first publication, one of the people who was reached by the GBD was Gro Harlem Brundtland, who was the then Director General-elect for WHO. And I remember meeting Gro at the Jolly Roger restaurant in DC for a breakfast, because she had actually read the GBD results and was, had noted a number of things in them, including the importance of mental health. And kind of long story short, that summer I moved to WHO along with Julio Frank, and to start a new program that she created around creating the evidence base. And one of the findings that moved on from that is that one of her first world health reports was on mental health, and that led to the first ministerial meeting on mental health, all of which triggered a number of countries, certainly not all, but a number of countries, to sort of pay more attention to mental health, to recognize it potentially as a real issue. And that led, I think, during Gro's time at WHO, to a rising set of policy discussions, and also on our metric side, more investigation and pursuit of the measurement around mental health. Something happened, though, around about the time that Gro Brundtland left WHO. She didn't run for a second term, and the rising tide of the Millennium Development Goals, where mental health did not feature, and the rising role of funding mechanisms like the Global Fund for AIDS, TB, and malaria, the Global Alliance for Vaccines and Immunizations, that although there was some level of interest in mental health, I think there was less momentum as there became more policy attention on the more central MDG targets. And it's sort of interesting to me that as we've transitioned into the SDG area, the exciting thing is that mental health has returned and has gotten more prominence. It's there as SDG indicators. And again, on the political pendulum, there's more interest in mental health than there was. But it is, there was that long period, I would have to say, of 10, 12 years where, at least on the policy level internationally, there wasn't a whole lot of net progress on mental health. So it's good to see that return. On our narrow part of it, on the quantification part, some of the problems that we had 20 years ago in measuring mental health are still there. We still have, and as the sort of measurement sophistication around the burden of disease has grown, and one reflection of that is, we have 200 people here at UW that work on the GBD, and we have 3,500 collaborators who work as part of our collaborative on measuring the burden of disease. And the main locus for our mental health work is actually at the University of Queensland, and Harvey Whiteford and his team helping to drive a lot of the quantification. But despite the much broader group involved, many of the challenges that we saw 20 years ago are still there. Namely, you have results across things like the World Mental Health Survey or other surveys that suggest highly heterogeneous results, even amongst countries that are quite near to each other. And the thing that bothers us all in the quantification end is How much of the variation from the application of current instruments is real variation, and how much is the differential performance of instruments in different cultures? And we don't really have the final answer on that. So as we think about the really important agenda of tackling this really large causal burden, we shouldn't forget about the need to strengthen the basis for the measurements. And I think they're interrelated, which is every time you try to get more attention on the policy side, we've seen that people want to interrogate, people from other diseases or risks want to know the strength of their competitors. And so you get more and more scrutiny of the underlying data and the measurements. And there are some outstanding issues that are there. There's lots of opportunities to measure some of the interconnections between mental health, for example, and death rates from other causes. So there's lots of directions to go. But I would say the work on the burden of disease has been part of this global narrative about getting mental health more on the policy agenda. But it is an ongoing story where it's not over. There's a lot of work on both the evidence around mental health, the evidence on intervention, and the evidence that interventions can be scaled at cost, because those are always the topics that return in any discussion in a policy environment.